Let's now deal with the normal anatomy and the clinical aspects of the ventricular system. And as you can see in the view shown on this page, this is a lateral kind of phantomized view of the location of the corresponding ventricles and their interconnecting channels. And note that every part of the central nervous system, the 5 secondary brain vesicles, including the spinal cord, basically contain a remnant of the neural canal, which in many places will be expanded to form a ventricle. And first off, the anatomy of the ventricles. In each hemisphere, in a telencephalic location, is a lateral ventricle. And we only show one of them here, but certainly since we have 2 cerebral hemispheres, we have 2 lateral ventricles. Note that there is a portion of the lateral ventricle in each one of the anatomic lobes of a hemisphere. Starting with the anterior horn projects up into the frontal lobe. The body of the lateral ventricle is mainly found in the parietal lobe. The posterior horn projects back into the occipital lobe, and the inferior horn extends down into the temporal lobe. But again, recognize that there are 2 of them. Note that each lateral ventricle is connected by way of a foramen of Monroe to a single third ventricle that basically is enclosed by the 2 sides of the diencephalon. So remember that there are 2 foramina of Monroe, each connecting a lateral ventricle to the third ventricle. Then, extending through the midbrain, which is the only part of the CNS other than the spinal cord that doesn't contain a ventricle, is the cerebral aqueduct of Sylvius. And that aqueduct connects the third ventricle with the smaller fourth ventricle that is found between the pons and the rostral medulla and the overlying cerebellum. Then extending down below the fourth ventricle is the central canal, which basically is found in the caudal medulla, as well as extends down the length of the spinal cord. Next point we want to make is that in parts of all of the ventricles, both the lateral ventricle, the third ventricle, and the fourth ventricle, are sites where we have choroid plexus. And choroid plexus is basically the site where we have a specialized epithelium invaded by choroidal arteries that basically results in the production of cerebral spinal fluid, which is in essence an ultrafiltrate of blood plasma. So note that the choroid plexus is found throughout the ventricles or in parts of them, but basically it's localized only in the body and the inferior horn of the lateral ventricle. It's on the lateral wall of the third ventricle, and it's kind of situated in the roof of the fourth ventricle. In the next view, the point that has to be made next is, on an average day, we are producing 400 to 500 cc's of cerebral spinal fluid, but the total volume of the ventricular system and the subarachnoid space is only about 150 cc's. The point being that all of CSF is a circulated fluid and must turn over 2 to 3 times a day because of the differences in the amount of secreted versus the volume of space that it can occupy. So the next point is all of the CSF that's produced in the ventricles must find an exit point to leave the ventricles to enter the subarachnoid space. And the point of this diagram, utilizing the arrows, shows the direction of CSF flow and makes a point in this mid-sagittal section that the only places where cerebral spinal fluid can exit the ventricular system and enter the subarachnoid space is by leaving the fourth ventricle through one of 3 openings. There are 2 lateral foramina of Luschka, one of which is illustrated here, and there is a single midline foramen of Majandi that's exiting from the dorsal wall of the fourth ventricle. So it is through those 3 openings that are the only places where CSF can leave the ventricular system, circulate about the entire subarachnoid space, including extending down into the lumbar cistern below the tapered end of the spinal cord. And then CSF is also not only a circulated fluid, it has to be resorbed through specialized projections of the arachnoid called arachnoid granulations that protrude into dural venous sinuses. A major location where you find these arachnoid granulations, as shown here, is at the point where they protrude into the superior sagittal dural venous sinus. So in essence, CSF is produced as an ultrafiltrate by choroidal arteries and basically it circulates inside and then around the outside of the entire central nervous system, and then it is drained back at the level of the arachnoid granulations into the dural venous sinuses. So the circulation pathway, therefore, of CSF is the following. CSF must leave both lateral ventricles by passing through an interventricular foramen of Monro to enter the midline third ventricle. And then all of the CSF that is entering the third ventricle must pass down through the narrow cerebral aqueduct and enter the fourth ventricle, which basically are its exit points into the subarachnoid space. So down at the bottom of this figure is basically the sum of the direction of flow of CSF, going from both lateral ventricles through the foramina of Monro to the third ventricle, down through the cerebral aqueduct to the fourth ventricle, and exiting out into the subarachnoid space via, as we say here, the foramina of Luschka or the foramen of Magendie. Then, view on the next page shows a coronal section of two of the dural venous sinuses. The one that's certainly the most important one for CSF drainage is the superior sagittal dural venous sinus. And you can see here that protruding into it by piercing the meningeal dura are a series of arachnoid granulations that are protrusions of the subarachnoid space. And at the level of these arachnoid granulations, this is a site where CSF flows down its concentration gradient and basically drains into those dural venous sinuses. Then, it's very important for exam purposes to be able to recognize the different forms of hydrocephalus. And fundamentally, there are two forms. Hydrocephalus is either defined as being a non-communicating hydrocephalus or a communicating hydrocephalus. And then we'll deal with the other subsets of these below. A non-communicating hydrocephalus is defined as being an obstruction to CSF flow within the ventricles. And it's also known as an obstructive hydrocephalus. Note that the blockage must occur at some point within the ventricles themselves or at one of the channels that interconnects a ventricle. Popular sites for an obstruction would be at a foramen of Monro or at the level of the cerebral aqueduct. Then, a communicating hydrocephalus is not an obstructive problem. It's most commonly an absorption problem at the level of the arachnoid granulations. Individuals that develop different forms of meningitis might irritate those arachnoid granulations and secondarily develop a communicating hydrocephalus. Communicating hydrocephalus may also be caused by a tumor in or some form of obstruction in the subarachnoid space, and or more rarely it may be caused by a choroid plexus tumor, an ependymoma, that basically results in excess CSF production. Next, normal pressure hydrocephalus is a common form of hydrocephalus seen in elderly patients. And this is typically again an absorption problem and therefore is a form of a communicating hydrocephalus. But in contrast, because as we age we lose neurons, CSF pressure in these individuals is usually normal, not elevated, because the ventricles are chronically dilated associated with neuronal loss. And in elderly patients, for unknown reasons, the NPH basically presents itself in a form of three characteristic signs and symptoms. These patients have a form of dementia, which is not a good localizing sign or symptom associated with just NPH because there are lots of neuronal conditions that cause dementia. But the other two are very characteristic of normal pressure hydrocephalus. One of them is these patients typically exhibit an apraxic, also known as a magnetic gait, where they kind of shuffle their feet along the floor as they walk because they're unable or less able to raise their feet off the floor. So it's known as a magnetic gait because they walk as if their feet are stuck to the floor. And secondly, these patients typically develop urinary incontinence as well, presumably because the bladder control neurons are situated fairly close to a dilated lateral ventricle. And typically in these individuals, a peritoneal shunt that shunts the excess CSF that's being produced typically in one of the ventricles is curative. Finally, individuals that have severe neuronal loss, patients with Alzheimer's dementia that are losing brain tissue that results from neurologic diseases, atrophy, stroke, so on and so forth, will also have dilated ventricles that are readily evident in imaging, but again will have normal CSF pressure and not the signs of a patient with NPH, but typically these individuals with wide varieties of neuronal conditions will have dilated ventricles, and this is known as hydrocephalus ex vacuo.